Thank you, Chairman, and thank you to all the participants. One of the victories of COVID was telehealth access, particularly for buprenorphine, for people who needed it, and unfortunately it expires at the end of this year. May I report to the world that all four of you witnesses would support extending that telehealth access? May the record reflect, well, is there going to be a record?
Well, we have streaming live.
Okay. All right. For what is, all four nodded in support, which is good. I think we'd very much like to get that done, Mr. Chairman. Rhode Island has had a pretty unique experience with our incarcerated population. We started a pre-release treatment regime for people scheduled for release, and saw from that a 61% reduction in overdose deaths in that population. That's a big percentage. And yet many incarcerative facilities don't provide that option. So I would like to see if you would support trying to extend that to as many places of incarceration as possible, so they're getting it first. Again, four heads nodding. Good, I'm doing really well here. And then to look at getting Medicaid to support those regimes for a period of time, 30 days, perhaps longer, after release, so that somebody isn't stepping out of the incarcerated facility where they get the medication into an environment in which they don't any longer. Would that be a good idea? 4 for 4, yes, great. Okay, the next one's going to be harder. We are looking at a bit of a conflict within the treatment community over expanding the availability of methadone, now through OPTs basically, to having any certified physician able to prescribe. And it strikes me that the merits of that proposal depend a lot on the geography of the site. That if you are in Montana, for instance, Dr. Horn, and it's a long way to a treatment center, that being able to go to the nearest certified physician and get a dosage, and to be able to get a fairly considerable dosage so that you can actually go home and not have to make the trek again, could make a lot of sense. You drop that same availability of large dosages for potentially long periods of time into an environment in which treatment is much more locally available, and suddenly the diversion problem begins to increase in prominence. And I would just like to propose, I don't know if any of you are working that problem right now, but it seems to me that there could be a distinction in that program between places where it makes a lot of sense because of access and geography, from places where it actually looks dangerous because of diversion. And if any of you have any thoughts on that, I would appreciate it. My time is pretty much expired, I would say. So if you have an instant thought, I think the chairman will let you share it, but I'd actually really appreciate it if you would communicate in writing with Chairman Cardin's office what your thoughts are on where it's sensible to have this work in different ways, recognizing the different facts on the ground that communities have to face.
This will not work with nodding of the heads. It's not going to work in that situation.
No. This is going to take actually putting pen to paper to.
It's a very thoughtful question, though. I mean, I don't think I would have put it together the way you just did, but there is a concern about diversions. There's no question about it. And yet there is so we've been trying to get the length of prescriptions shortened because of diversion. And now you talk about in areas where you don't have the same services and you need the continuity of care where you need to have a larger amount. It's an interesting point that Senator Whitehouse is raising. So we would be interested if you have a way that that could be handled within the regulatory framework of the federal government or by legislation.
Thanks, Chairman.
I'll try to be quick. So, I think one thing is some of the legislation that's being proposed would restrict methadone prescribing to people who are addiction medicine physicians or have specialized training. So it would be like the first step would sort of be more incremental in a way, and to address the sort of concern about sort of a significant increase in prescribing. I think, too, is sort of, as we've just been talking about sort of these integrated models and people being able to go to places to be able to receive primary care, behavioral health care, work with peer recovery coaches in sort of a non-stigmatized regular healthcare environment. I sort of think about methadone the same way, sort of being able to sort of not silo it and sort of being able to offer it as part of sort of just general regular medical care so that people don't have to like go to the clinic and feel like it's not just part of the regular health care that they're trying to access.
I think that the problem comes when, because of remote location and lack of access, you're sending somebody away with a fairly considerable dose of methadone to last them for, 2 weeks or a month or whatever the period is. And if somebody's heading out to someplace that's pretty remote in a small town or on a ranch in Montana, then that makes quite a lot of sense. But if you've got an urban community that has lots of people who suddenly have access to lots of methadone, I do think it creates diversion issues in that very different situation that we should try to work our way through. And so that was my suggestion.